Hey, good day. Welcome to Chapter 10, Patient Assessment. This particular chapter is one of my favorites, and it most certainly, besides pediatrics, that is my favorite. Most certainly, patient assessment has to be number one. This is one of those things that, as an EMT, you got to be able to do this, and you have to get really good at it. In order to be a good entry level paramedic, you have to be an awesome EMT. And your foundation behind being an EMT is patient assessment. You got to be able to touch patients, talk to patients, be able to clearly speak with them and give them the information that they need to be confident that you're going to be able to save their lives. So let's get started. Like this slide says, it's one of the most important skills. We're going to break it down. Very simple. Patient assessment is the basis for all treatment. We have 5 points of the assessment that are super, super duper, duper, duper important that you're going to have to memorize. And throughout this course, I'm going to be asking you over the next several weeks, what is the first point of the assessment? Scene size up. What's the second point of the assessment? Primary assessment. What is the third point of the assessment? History taking. What is the fourth point of assessment? Secondary assessment. And what is the fifth point of the assessment? Reassessment. So let's break this all down. Patient assessment is the basis for all treatment. It's how we make our clinical decisions on what's wrong with our patients. There it is. 5 main parts. 5 main parts. This is the order in which these steps are done. It doesn't happen any other way. It happens this way. All of your assessment skills are going to be honed around this particular 5 points. Yes, there is some more to these 5 points. We're going to talk about these in detail. By the end of this course, you need to be proficient at this. You need to be able to be tested upon this. And this is the one thing you've got to be able to do on your own. You have to demonstrate competency on this particular skill. So, rarely does one sign and symptom show that a patient's status has an underlying problem. So what we need to do is we need to talk about what a sign, what a symptom, and what we're doing with our field impressions. A symptom is simple, okay? It's a subjective condition that a patient feels and tell you about. A symptom is something that they tell you about. A sign is something that you see. It's an objective condition that you can observe about the patient. When we talk about later, much later, about writing chart and writing SOAP, SOAP stands for subjective, S, okay, and then sign, objective, O, field impression, evident cause of the patient's condition, determined by considering the situation, history, and examination findings. These are 3 little tiny pieces that we're using as our detectives. Remember, we talked about that. You got to put that hat on. You got to look for the clues and start making your decisions based on it. But one sign or symptom really doesn't tell you the whole thing. It's a group of things. You got to put it together. You got to critically think and decide what you're going to do. All right, so scene size up. Scene size up is your evaluation as you first pull up. We also like to say windshield survey. It's what you see through the windshield as you're driving up. You got to be careful. Things will get you. Scene size up is one of those things that all builds itself around situational awareness. Otherwise, swivel on your head. You need to be aware of what the heck is going on before you get out and start messing with the scene itself. You got to make sure it's safe. There's no dogs. There's no ostriches running around, emus or camels or whatever the case may be. Anything that's going to hurt you, hurt others, hurt your partner, that kind of stuff. So scene size up combines an understanding of the situation and condition. The dispatcher basic information is what gets you started, okay? When you're on the way and you know it's a car accident, you need to be looking for fire, you need to be looking for hazards, you need to be looking at things that'll get you, okay? So information that dispatch will give you help you a lot. Then the observation of the scene itself. So ensuring safety. Issues range from little ones to big ones, okay? They can be fires, they can be, like I said, dogs, they can be, electric fences, they could be all kinds of things. If the scene is not safe for you and your team to enter the scene and approach and treat the patient, take appropriate measures to make it safe, okay, or call for additional resources. Take appropriate measures to make it safe. Yes, there's things that you can do to make it safe. And if you can't make it safe, call for additional resources. Don't forget about traffic on these car accidents. You got to be careful. When you get out, make sure you have your vest on. Make sure you're extremely visible. In Europe, they wear basically day glow clothing, pants and tops. In Europe, a lot of places in the Middle East and the Philippines, they're very safety conscious. They look like orange people or green people. They wear big time safety reflective clothing. You need to do the same thing. There are safety vests that are provided for you, safety clothing that's provided for you. Make sure you're working with or using that when you're working on a roadway. Use your vehicle to block traffic, especially big fire trucks. If you have a big fire truck, block the traffic. Absolutely, so that you can make it safe for all of the team members while they're working on the scene. There you go. There's the scene there. Okay. Notice lots of fire. Tractor trailer looks like, the tractor has been separated. But anyhow, notice how they have all that reflective gear on so that they're very safe and they can be seen. That's their turnout gear with reflective stripes on it. All right. So considerations. Environmental considerations. Consider the scene. Are there hazards? As you can see here, there's a law enforcement officer putting up caution tape. They're lifting up the tape, hopefully, to let people through that need to get through or get out, that kind of stuff. If it's appropriate, help protect bystanders as well from becoming patients. Many times, if you are on a scene and everyone has died in the car accident, which does happen, a lot of bystanders out there, a whole lot of bystanders. And make sure that you remember too, these bystanders, many of them are utilizing cell phones to film that scene. You don't want this to come up on the nightly news. Do what you can. We work with law enforcement to get these people away from the scene. It's no good for them, no matter what, being close to it, but it's also no good for the privacy of the deceased as well. So be aware. Be aware that there's always a potential for some kind of violence, stuff that can come on, very suddenly. If you have domestic violence issues and you're working with somebody who's injured in this, even a car accident by which, the children have been ejected from the vehicle and the parents were wearing their seatbelts and the children weren't, they may get very upset and angry because of this and interfere with what you want to do. There's also a lot of physical stuff that'll hurt you too. Broken glass, metal, those kind of things. Don't get into that kind of involvement without the proper gear. Also biohazards, and we're going to talk about this much later. When we talk about infectious diseases, we mentioned some of it back in the wellness of the care of the EMT. But biohazards such as blood and bodily fluids is one of those things you need to be careful with. Chemical hazards and materials, we have a way to protect ourselves with that. We are going to talk about that, but there are definite hazards and chemicals. Trucks carry them all the time, or anytime you get into, close to a fire, there's toxic gases that are being emitted from that. Electricity, water, fire, explosive devices, these are all kinds of things. Physical violence, you need to be aware. It's like we always say, swivel, head on a swivel kind of thing. Be looking around and get that situational awareness going on. As an emergency scene develops, it changes very dynamically. You can get violent family members that come up all of a sudden, patients themselves that you may be dealing with in a behavioral crisis, angry bystanders, gangs, unruly crowds. If you're not yet on scene but suspect it may be dangerous, stage in a safe location until law enforcement advises it's safe to proceed. That's a big thing. And most of the time when you're dispatched, dispatch will already have a handle on this and they'll tell you to report to a staging area. and you'll wait there until the scene is safe. Anyhow, bottom line, that last statement there, all scenes are very dynamic. They evolve, okay? They evolve and they change and can become hazardous at any point in time. Determine the mechanism of injury or nature of illness. What this means, MOI versus NOI. MOI, mechanism of injury, those are your trauma patients. NOI is nature of illness. You can have both of these at the same time. You have the person that had a heart attack and then crashed into a tree because they were driving when the heart attack occurred, or fall off a ladder, or anything. So it can be both, okay? Calls for assistance, what you're responding to can be either one. And so therefore you need to make sure that you understand the differences of the two, and when you have a combination of the both. When we talk about mechanism of injury, and there's a whole section on trauma, there's a lot of physical forces that are applied that we'll talk about at that point in time, and the injuries that can be caused. Basically, it's either blunt trauma or penetrating trauma. Blunt trauma means you got hit with something, or you were inside a vehicle and you crashed into something and your chest hit the steering wheel. That's blunt trauma. Versus penetrating, you get stabbed or you get fallen on a piece of metal and it goes through your body, those kind of things. So that would be penetrating. We'll talk about that later in trauma. The MOI indicates the need for spinal motion restriction. If we have a patient who's unconscious, we implement protocols which are called spinal motion restriction, okay? Is to ensure that we make sure the patient is stabilized as far as their spinal cord is concerned. Protocols differ from, different locations, so make sure you know your local protocol on this. But, it's at least when you have somebody who's unconscious, you want to have somebody hold C-spine. And we will talk about this in trauma in depth, but they hold the patient's head into a position where the airway is open and the head is stabilized the best that they can, okay, while you're doing your assessment. So it's definitely indicated in the context of blunt trauma that presents with any of the following. If the patient has pain or tenderness on palpation of the neck or spine, if the patient reports pain in the neck or back, or if there's deformity of the spine, or if the patient has any kind of paralysis or neurological complaints, such as numbness or tingling in their feet or in their hands, or partial paralysis of the legs or arms. And then, of course, altered mental status, which also includes if they're intoxicated, either by alcohol or by drugs. Another thing, too, is difficulty communicating or ability to communicate, and we don't know what's going on, and there's a significant mechanism of injury. That's what we talk about. And if they have really bad injuries, distracting injuries, otherwise, multiple fractures of the extremities, and we can't really assess the spine, then we're going to consider spinal motion restriction. But do follow whatever your local protocol or standing orders are about. And if you're not sure, you can always contact medical control. Terms commonly associated with MOI, we talked about this: blunt trauma and penetrating trauma. Other things too, medical patients, we need to determine that nature of illness. What is their chief complaint? And we want to know what is the most serious sign or symptom that the patient's experiencing. Chief concern, condition that's most urgent intervention as determined by the clinician. Otherwise, whatever that chief complaint or chief concern, the most important one, whoever's in charge is going to make that decision. So if the patient says, I'm kind of short of breath, but my chest really hurts, it's bad, then the chest pain would be the chief concern of that patient. It would be the worst presenting symptom of the patient. And then if you saw signs, the patient is, red in the face or blue in the face, pale in the face, that kind of thing, and sweaty. Those are signs that this person is in dire need and could be a life-threatening type of condition. Be aware of scenes with multiple patients who have similar signs and symptoms. If they're all dizzy, they're all complaining of headache, something's gassing them or something is making them sick. It could be unsafe. That happens. I know we don't have very many malls anymore, but you do have areas of, where there's concerts going on and that kind of stuff. If there's, not enough breeze going on and they're right close to the stage and they've got generators running, there could be carbon monoxide poisoning in the crowd. Everybody's complaining of a headache and everybody's kind of look red in the face kind of thing. That's very serious stuff. You need to clear them out of there and make sure to get them to fresh air. So be aware of that. If they're all complaining of the same symptoms, something is making everybody sick. So it may be unsafe to be there. All right, so importance of MOI and NOI. Hey, this is telling us whether it's trauma or it's medical, or it's both, and it can be, just like I mentioned to either, or like I mentioned to before. And there's a certain pieces of the assessment that changes a little bit in the dynamics for trauma patients versus a medical patient. So our emphasis on trauma is bleeding first, okay? Bleeding, 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 versus our patients that are medical, it's airway, and circulation, depending on the circumstances. If the patient's unconscious, it's circulation, airway, breathing. If the person's conscious, it's airway, breathing, circulation, disability, and exposure. So we'll talk about this as we progress into the assessment portion of it, but know that they're slightly different in the assessment. Not much, but a slightly different approach. All right, so standard precautions. We have to protect ourselves. We must protect ourselves from any kind of situation that we may get into where we may be exposed to bodily fluid or secretions. Notice in this particular case, the paramedic, she is wearing gloves to start with, okay? She's also wearing a mask and she has got a set of goggles on, all right? So you can see them. I'm point in the area, you just kind of got to look at it a little bit closer. So she's got goggles on, which prevent any splashing of blood. You have been issued these in your backpacks. You must wear your eye protection. Splatter protection is number one. And just a pair of cheap old sunglasses is not going to help you. It's not going to protect you, and you can't wear those in the dark. So you need to wear the clear provided safety glasses. Mask, if you're instructed to wear a mask, there's a reason. If a patient's coughing and they can't wear a mask, you should wear just a simple mask. Any other specialized mask you'll be instructed to wear by your preceptors. Gloves, all patients. Listen, in lab, I will buy truckloads of gloves if I have to. You use gloves on every single mannequin you touch and when you touch each other, because it is a great way for you to prevent you giving some of the germs that are on your unwashed hands to somebody, or for you to get something in any kind of cut that you may have or open wound that you may have on your hands by the way of bodily fluid from your patients. Plus, also, it keeps my mannequins clean. So, anyhow, help me out there on that. So, very much so, every amount of your personal protective equipment or PPEs that you wear is based on the condition. Okay, it's based on what you're getting into. All right, so protective measures recommended use in dealing with objects, blood, bodily fluids, other potential exposures. We've talked about this, and in your chapter 2, remember, we talked about how to put on gloves and how to pull them off properly, how to prevent and report exposures, those kind of things. So you need to make sure that you use those PPEs effectively so you can prevent or reduce some of the spread of disease. All right, so assume that everybody's infected. Every drop of fluid, no matter what it is, including sweat, it's bad stuff, okay? Biggest thing about what's at risk is non-intact skin. If you have a cut, abrasions, those kind of things on yourself or the patient does. And the mucous membranes inside your mouth, inside your nose, inside your eyes. Those can get very easily exposed and you can get a transfer of what we call a loading dose or a higher dose of a pathogen that could make you sick. So we want to stay away from that. So during any situation in which there's an active community transmission of a virus that can be transmitted, by airborne, particles or aerosolized particles, this concept of standard precautions must be expanded to recognize the risk of associated of non-bloodborne pathogens. So therefore, if it's airborne, wear a mask. Wear a simple surgical mask. If the patient can wear one, put one on them. If you can wear one too, both of you wear one. There's no problem in that. Protect yourself. When I work in the hospital, I wear a mask every time I walk into a room of any patient that has any flu, cold-like symptoms, or if they just have a cough, period. That way, I help to reduce the transmission that I'm getting from them. And also, I'm not transmitting anything out to them, because if they are sick, their immune system's already weakened. So think about it. You're protecting each other on this. Take standard precautions before actual patient contact, just like I said, but at minimum, gloves and eye protection. At minimum, gloves and eye protection. When I work both in the ambulance, helicopter, and aircraft, my safety goggles hang around my neck all the time. Kind of like my sunglasses. I'm very sensitive. My eyes are sensitive to sunlight, so I wear sunglasses. So when I need my safety glasses, I have them around my neck. Okay, I also have my sunglasses with a string on them attached as well, but it's longer than my safety glasses. My safety glasses are more close to my neck. The band is shorter, so it holds it close and tight to my face, because I tell you have a lot of activity go on, they can fall off, and we don't want that. If I'm working on a patient, I don't want my safety glasses to fall off. When I put them on, they're tight on my head, so they won't do that. And then, of course, a mask, a simple surgical mask, will provide some protection from airborne diseases. So, if the patient can't wear one, you wear one. It's that simple. All right, so we're on scene. We're all PPE'd up. We've got everything. We need to determine the number of patients. Whoa, boy. This is definitely an exercise in front of the portfolio kitchen and home somewhere. I'm not sure where it is, but it's somewhere. And they're doing an exercise. As you can see, there's lots of red shirts out there. This is what we call a mass casualty incident exercise. You will participate in one of these when we get into operations. We're going to have one here to practice on, so you'll be triaging patients. But the biggest thing that we know is when there's a multiple casualty incidents, is when you first pull up and there's too many patients than the resources that you have. In the resources that you have, it's you and your partner. There's not a whole lot you can take. Your partner can take care of one patient, and you can have, a family member sit up front, kind of thing. So if we have more than one patient, we need to be calling for help. You need additional assistance here. So it's critical to determine the need for support right away. You pull up and you see a lot of people. You see several people in one car that are injured, several people that are in another car that are injured. When you report that you're on scene, say we're on scene of a multi-casualty incident, we'll need 2 additional ambulances. So you'll start there first, okay? Once you get out, you know, you'll start dealing with the scene. You'll get an accurate count. Then you'll report back to the dispatch of how many patients you have and what their priority are, what their triage priority are. And we'll talk about this when we get to triage. We'll talk about how we triage patient and the categories that we utilize. And one of you will be establishing incident command when you get out on a multiple casualty incident. One person will be doing triage. So whoever's a senior person, that has the most training should actually be your incident commander. And then the other EMTs should be doing the actual triage. So it's a sticky situation, and hopefully you don't ever have to get into it. But if you stay long enough in the field, you will. Absolutely. Specialized resources, well, here they are, advanced life support, air medical support, fire departments, specialty teams such as hazardous materials, high angle rescue, those kind of things, and of course, law enforcement. This is what we're made up with emergency medical services. We're all made up together. We all work together to make sure that we do no harm and get the best care for our patients. There's your hazmat guys. They look like Ghostbuster guys or something, right? But these are level A suits. They protect against contaminants. If you roll up on a scene and you see, like on a highway, and there's a truck overturned and a lot of people laying around not moving, don't go in. Back up, try to get, upwind, from the incident so whatever the hazardous material is blowing away from you. And then report what you got going on. Get your binoculars out and try to identify by using your hazardous material book to identify what the source of the chemical in the truck is by looking at placards. We will talk about that later once we get to that point in operations. All right, so those additional specialized resources to continue. Does the scene pose a threat to me, my patient, or others? How many patients are there? Do we have the resource to handle it? These are the questions you're going to be asked when you first pull up on scene. So let's talk about our geriatric patients just a little bit. Some considerations on scene size up. All right, so elderly people or geriatrics, they're commonly found in their homes, retirement homes, or skilled nursing facilities. So they have a different kind of environment that we most primarily respond to. Make sure that when you go in, look for any negative things, especially if they're living at home by themselves. How well is the house kept up? Does it look like, they're checking their mail? How's their refrigerator look? Has it got food in it? These kind of things. Because you're also an advocate for your patient. You're not just there to treat whatever the 911 call is, especially advocates for people that can't help themselves. The elderly patient, the young patient, the special needs patients. These are the patients that you truly need to be the advocate for. In a care facility, you'll locate the staff, you'll locate the patient's room, you'll get a report, you'll receive whatever paperwork that you need to take to the hospital, those kind of things. If the mental status is altered of your patient, who's in charge here? Who's responsible for the caregiving of this patient? Okay. And when you find that person, ask them, is this normal for this patient? Is this normal behavior? Because if it's not and it's altered, then you have a problem. It may be a sugar problem. It may be a neurological problem. So there's many things to consider that we need to ask questions about. Other thing, nature of illness could be difficult. Especially if they have altered mental status, they have dementia, they have, senile dementia, those kind of things, or organic brain syndrome. They have something going on in their life that's altering their mental status. Don't forget sugar levels. We must assess what their sugar. And we'll talk about this. There's a skill drill for this. You get to test your sugar on each other. And yes, that's you got low glucose and you won't be with it. You'll have altered mental status. Same way with high as well. You can be very altered with high. You could act like you're intoxicated. So if you have a family member or a caregiver relevant to them, ask those questions. They may have lots of chronic diseases. Okay, they may have congestive heart failure, COPD. They could have asthma. They could have coronary artery disease, or all kinds of things. They could have had a stroke. These are questions that we must ask. It all comes out what we're going to talk about here in a little while about sample history once we get out of, this particular side into our surveys. So chest pain, shortness of breath, altered level of consciousness should always be considered serious. Number one, bam, check it on your list. Bam, there it is. Okay, let us talk about primary assessment. Folks, the very first thing I do after we've gotten through the scene size up, scene survey, everything is fine. When I walk into the room and I approach my patient, if the patient is conscious and alert looking at me, I introduce myself by name. Hi, my name is Jeff. I'm a paramedic. What is your name? Because I want to know what their name is. It lets me know that they cognitively remember who they are, and I know what to address them by. I can speak to them by their name. Oh, hi, Fred. Great. I'm glad to be here. Okay. Then I want to establish what level of consciousness they have. What we're looking for is we're looking for alertness for person, place, time, and event. Well, I know person because he told me his name was Fred. Okay. Then I'll ask, where are you at right now, Fred? Fred says, I'm at home. Okay, great. Then I say, what time is it, Fred? Is it daytime or is it nighttime? He says it's daytime. Okay, great. He knows it's daytime. And then I'll say, what happened? You called 911. What's going on today? And then he starts to explain why he called 911. Guess what? I got person, place, time, and event, okay, just by talking to him in the first 10 to 15 seconds. I also, if the patient will allow, I like to touch the patient. I'll put one hand on a shoulder, okay, and the other hand on a radial pulse. And we'll talk about that radial pulse later about how important that is. If I can feel it, I'm a happy camper. I'm also feeling with my other hand, I'm creating a rapport that I care. Patient knows that I care because I'm touching them. Sometimes people won't let you, but usually they will because they want help. That's why they call 911, even if they just want to talk to somebody. My hand also is a temperature sensing device. I can feel how hot this person is. Sometimes I can feel that they're wet, their clothing is wet, that kind of stuff. Even though I've got gloves on, I can tell. I can look at my gloves and see that they're damp. So it gives me a lot of information. So when we're establishing the level of consciousness, we also want to consider airway, breathing, and circulation. Folks, I want you to remember something. Normal breathing is silent. When you walk into the room, if you don't hear them breathing, it's probably normal as long as they're looking at you and their chest is going up and down. If they're unconscious and they're not breathing, then it's a whole different story. But if they're looking at you and conscious and you don't hear them breathing, more than likely there isn't an airway obstruction because that leaves me where air is, or airway, A is. Airway is what's the quality of their airway? Is it clear? Is it obstructed? You know, has it got something in it? Has it got tobacco in it? Has it got those little nicotine packs in it? Are they chewing gum? Do they have dentures? So the airway is important. And then finally, circulation. That goes back to that pulse. If I can feel a radial pulse, I know you have a blood pressure of at least 90 systolically. That's good. That's very good. Okay, that makes me happy. If the patient has obvious life-threatening external bleeding, otherwise it's a trauma, XABC. X stands for extenuating bleeding, okay? Or hemorrhage, okay? Massive hemorrhage. We also use another acronym called MARCH in trauma, but we're going to just leave it at XABC right now. That's what it says in your book. So exsanguinating hemorrhage. So trauma, add the X to it. Okay, trauma, add the X to it. ABC. All right, so life threat, you got to determine that right away. That's why we're in our primary. That's what it's supposed to do. Okay, that's what we identify. Conditions that cause sudden death, they're all here. Okay, they're here in front of you. Airway obstruction, respiratory failure, respiratory arrest, shock, severe bleeding, cardiac arrest, or intracranial hemorrhage such as acute hemorrhage. That means intracranial inside the head. They're having a stroke. That's an intracranial hemorrhage, okay, or intracranial event. It also could be a blockage. We have two different types of stroke. We have an ischemic stroke and a hypoxic stroke, and a stroke where there's a blockage, an obstructive stroke. So, you know, that's when the clot gets in there and it clots it off and the blood can't get to the brain. And then the stroke that's a hemorrhagic stroke, okay, which is our next one. The hemorrhagic stroke is when the vessel is ruptured and it's bleeding inside the brain. So these are all conditions that can cause sudden death. They're life threats that we need to look out for. So forming a general impression. All right, so our primary survey, All right, so we got level of consciousness, patient's alert and oriented, person, place, time, and event. That general impression is when you're walking in, okay? Is there any bleeding? If there is, you stop the bleed. I just told a team member to do that, okay? I already know the scene's safe. You stop the bleed, okay? I'm also noticing as I walk up the age, sex, and race of the patient, the level of distress. Are they in acute distress, moderate distress, mild distress, or no distress? And their overall picture, their appearance, okay? Are they purple? Are they blue? Are they pale? Are they mottled? Are they conscious? Are they unconscious? This drives me to what kind of assessment that I'm going to perform. All right, so this patient here, what do you think? Just at the overall look. All right, so side of the road, okay, perhaps homeless, don't know. Love those shoes, man. Those are some nice shoes. But is she sleeping or is she unconscious? One or the other. So you're going to walk up, hey, ma'am, are you okay? Okay. Hello, my name is Jeff. Hello, I'm a paramedic. I'm here to help you. If there's no response, I might get a little closer now and tap. Okay, tap on her and see if she does arouse. If nothing happens, then I'm going to feel for a pulse. But sitting in this position with her hands upright, her knees flexed like that, head off to the side, she very well may be just sleeping, but we need to arouse her. We need to establish responsiveness. Is she responsive or unresponsive? She's one of the two, but we've got to try to arouse her. All right, so the initial general impression continues during your introduction. Ask them about your chief complaint. What's going on today? Remember that event. Person, place, time, and event. The event, what's happening today? What prompted you to call 911? I'm here to help you. Okay. And of course, life-threatening problems such as bleeding, or if they're unconscious and they have a snoring airway, they're blue in color because blue is bad. Blue is very bad. Air ought to go in and out. Blue is bad if it ain't going in and out. Okay. So make sure that we're looking at those life threats. Bleeding's that biggest one when you first walk up. So you treat those immediately, and you as the team leader doesn't do the treatment, you designate that. You stop the bleed. You get airway, check breathing, put on oxygen. Okay? These are kind of things that you're going to delegate. As team leader, it's very important for you to delegate and learn that process because you're going to be tested on this. You've got to demonstrate to us by the end of this program that you can do a patient assessment on your own. You can recognize life-threatening injuries or life-threatening conditions, and you can delegate to somebody to fix it. Fix it. Stop the bleed. That's a beautiful thing. You got to make sure that you get people on that. Scans for sign of uncontrolled bleeding. We just talked about that. Another thing that we really like to do, especially the unconscious patient or the patient is badly injured, we call it blood sweeping. Take your hands really quick. You're going to check from head to toe. This is called a rapid trauma assessment. Head to toe, you're going to look at your gloves and see if you find any bleeding. You may see the bleeding. It may be just pouring out all over the place. So you've got to delegate somebody to stop it. You stop the bleed. And you only have to say stop the bleed because the other trained person and the other EMT that has equal training as you will know, we apply pressure. If the pressure doesn't work, we're going to go, a little bit more aggressive. We get a tourniquet, put a tourniquet on, those kind of things. They're going to stop the bleed. That delegation is so important as you being the team leader and being the assessor of this patient and control of the scene. Level of consciousness. We've talked about this. Person, place, time, and event. It can tell you so much about your patient. So you need to establish that level and make sure you understand where they're at. AVPU, awake and alert, responsive to verbal, responsive to pain, and unresponsive. There's an actual scale that we assign numbers to, but we hope everybody is awake and alert. And then are they A&O times 4 or 2 or 1 or whatever? You have to establish that by asking questions. If they're not, They may only respond to verbal stimuli. Hey, 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 what, and then back asleep or whatever, back unconscious again. Or they may only respond to pain, or they may be completely unresponsive. When we talk about pain, we're talking about painful stimuli. You will elicit a painful stimuli. Do what you need to do and what your protocols say, but I will tell you, you'll see sternal rub, you'll see about pinching the finger, those kind of things. I like to do things that are not quite as noticeable. If you're sitting there doing a sternal rub on somebody's chest and their family member standing there, they may get upset at you. That in this day and age, when you have cameras everywhere, everybody's got a camera on their cell phone. They're filming you do that. It doesn't look good. So just reach down there and curl their little pinky over and squeeze down on it. And that causes enough painful response. It's really not noticeable that you're doing it. I'll show you that in class, or one of the instructors will show you as well. So ask about it. So anyhow, or they're unresponsive. If they're unresponsive, we do the CAB process, the algorithm that you learned in chapter 14 for the unresponsive patient. All right, so determine whether a patient who does not respond to verbal stimuli, gentle firm pressure, squeeze a patient's tissue, it's like I said, apply pressure, whatever. Just try to do it unnoticeably. A patient who moans or withdrawal is responding to the stimulus, and they actually get points for that. A patient who remains flaccid, doesn't move, is considered unresponsive. So we need to be assessing that. Here's an example. Notice that they're squeezing the trapezius area of the neck of the shoulder. That's a way to do it. And again, really nobody's paying attention, nobody notices, but it will elicit a painful response. You squeeze pretty firmly, and if there's no response to that, they're deeply unresponsive. All right, so orientation test. Hey, we just talked about that. There you go, person, place, time, and event. Told you, it's there. Introduce yourself. Do they know their name? Okay. Do they know where they're at? Are they in the house or in the hospital or in the field, in their car? Do they know what time it is? Nobody knows exactly what time it is. I always say daytime or nighttime. Then finally, event. What'd you call for? What happened? What's going on today? Why are we here to help you? What do you need from us? Let us know what's going on. What happened? These are very good things. You're establishing a rapport. You're trying to make them comfortable. This could be the very worst day in their life, or it could be the best day in their life. They're having a baby. Yay, that happens, So anyhow, it's not always bad stuff. It can be good stuff too. So anyhow, hey, we're there to help. Person, place, time, and event. All right, airway, assessing the airway, air obstruction. We talked about this, okay? If the respirations are noisy, we've got some kind of problem, okay? Airway obstruction can result in partial or complete blockage of air movement into and out of the lungs, and therefore it ends up subsequently causing inadequate perfusion. So as you move your way through the primary assessment, identifying life threats, you need to assess ABCs. How is the airway? Is it open? Is it clear? Is the air going in and out? Are they able to maintain their own airway? What's the ventilation rate? Do you see chest rise going up and down equally, or is it unequally? All these things. Do you hear? Is there something noisy going on with the breathing? If there is, we got problems. Okay. Responsive patients. Patients who are talking and crying, they have an open airway. No problem. A conscious patient who cannot speak or cry most likely has a severe airway obstruction for some reason. You got to identify it, and if you can, relieve it. If you identify an airway problem, stop the assessment process and work to clear the patient's airway. I'll give a perfect example. I had a patient the other day, a few weeks ago, who fell off the back of a truck because he had been drinking face first, and he had basically exploded his face, and he had teeth in his mouth, and I noticed what looked like toilet paper. I didn't know what it was, so I started suctioning out the airway, and come to find out, it's the nicotine packets that come in a little can that you can buy at the convenience stores and that kind of stuff. He was choking on that stuff, and it could have went down into his lungs, so we need to clear out the airway. So you may find stuff in the airway. Suction, suction, suction. You've got to have suction. So important as an EMT skill. We're going to practice that skill until you're proficient at it. If your patient has signs of difficulty breathing or is not breathing, we have to take corrective measures. You're going to have to breathe for them. Unresponsive airways. Listen, hey, unresponsive patients. If a patient lies supine, their big fat tongue falls over the back of their airway, you'll either hear snoring or no respirations. Open the airway. Head tilt, chin lift maneuver for nature of illness patients. If it's you suspect trauma, we'll do a jaw thrust maneuver. And we're going to teach you all this in airway. If there's potential for trauma, there it is, jaw thrust to open the airway. Sorry, not reading about that. If the airway cannot be opened, facilitate that. Remember, we also have what we call airway adjuncts, and you'll be taught about this later. We have oral pharyngeal airways, nasal pharyngeal airways. We have a wonderful airway that EMTs and first responders use called the I-gel. We're going to teach about all these kind of things and how wonderful they are to keep the airway open. Obstructed in the unconscious patient, obvious trauma, blood, just like we were talking before, that guy's teeth and the little nicotine packs and those kind of things. Or noisy breathing, snoring, bubbling, gurgling, crowing, anything that's abnormal. Remember, normal respirations are silent, or if they're extremely shallow. One of the things that I see with EMTs that they tend to forget and miss on tests, especially scenario tests. Do not forget, if the patient is breathing at 4 times a minute, that is inadequate. You must breathe for them. Mechanical breathing is used, we use a BVM, bag valve mask. Don't put a nasal cannula on a patient breathing at 4 times a minute or a non-rebreather mask. You will not pass that skill. You have to recognize that 4 breaths per minute is not adequate, especially if they're shallow. Even fast breaths at 36 times a minute and shallow, is not going to be adequate. So you're going to have to overdrive ventilate them with a bag valve mask. And we'll practice all this. It'll be in scenarios. I'm just warning you ahead of time. Once you've made sure the airway is open, make sure that the breathing is present and adequate. So remember airway and breathing, ABC, airway, breathing, circulation. Airway, we just talked about. Breathing now is the breathing. Is the patient breathing at all? Okay. What's the patient's breathing rate, rhythm, and quality? Remember, the reason why you got to have a watch, you got to count respirations. And the second hand sweep watch is the easiest to count. If you're trying to fiddle with it and try to get some numbers going on, your patient's not breathing, they're turning purple, and you're trying to figure out how to work your watch, that's no good. When a watch with a second-hand sweep is always working 24/7. Doesn't stop until the battery dies, so it's much easier to utilize. So rate, rhythm, and quality. When you assess patients and we're doing scenarios, I want you to remember for A, open it, clear it. B, rate and quality. C, rate and quality. Because in B, breathing, rate and quality, how fast is it and how good is it? Okay, how fast is it? How good is it? And is the patient showing any signs of hypoxia? Are they blue? Hypoxia means without oxygen. Look that up. That's vital vocabulary, folks. You need to know that. You will see that on a test. Positive pressure ventilation should be performed. Bag valve mask. If they are too shallow or too slow, we just talked about this. Please make sure you do this or you will not pass that level of scenario, okay? The goal of oxygenation for most patients, okay? The goal, 94%, okay? The oxygen saturation is a device called a pulse oximeter that we place on the patient. We'll teach you this in airway. Goes on the finger, can go on the ear, on children or elderly, and other infants. We can also put it on the toe, that kind of thing. It measures or counts the amount of molecules that are on the red blood cells, okay? Assess the rate and depth and determine if the breathing is adequate. And if it's not, help them out. Breathe for them. provide mechanical ventilations. That's simple, simple, simple. It's not hard. This is not hard stuff. The recognition is the key. You've got to recognize it. Got to recognize the patient's in trouble and do something about it. Rhythm. Most people inhale and exhale over 1 to 2 seconds with a short pause in between for each breath. Irregular includes shallow or deep inhalations followed by periods of apnea. Vital vocabulary, apnea. That means without breathing. Pana means breathing. Means without. Okay, that comes from medical terminology. Tachypnea means fast breathing. Bradyapnea means slow breathing. Apnea means no breathing. Know these terms, folks, because you need to use them when you're talking with each other, when you're communicating with other clinicians, and you got to know it for your test. If you don't know the vital vocabulary, you're going to fail. Okay, let's not do that. Remember what I said in orientation. Read your book, know your national standard competencies, know your knowledge objectives, and your vital vocabulary. And you should do well. Okay? Shallow respirations can be identified by little movement of the chest wall. Reduced tidal volume. Tidal volume, remember, tidal volume is the amount of air that can be capacity in the lung on a normal breath, okay? Or poor chest excursion. Otherwise, the chest just isn't moving up and down. One side may be going up, the other side's not. Maybe you see part of the chest suck in and then come out, suck in and come out. That's flail chest. We'll talk about all that during trauma. So what are the good? And that's part about it. We need to expose the chest so we can see it. Expose the chest because we can see it. We need to be able to see when we have injuries to the chest or when we want to listen to the chest. Don't listen to chest lung sounds with your stethoscope through the clothing. You must get underneath the clothing. And if you just very, modestly put your hand up with your stethoscope on the bell, would teach you this. Go up inside the clothing versus undressing. Most commonly, we undress our patients, especially our patients that are in life-threatening conditions. We don't have time for clothing, so we're going to remove the clothing and take care of our patient. But a patient who's conscious and alert that maybe just has some difficulty breathing, you don't have to rip all their clothes off. Be conscious about their modesty. Observe how much effort's required. Okay? Rate and quality. Rate and quality. Presence of retractions, use of accessory muscles, nasal flaring, which is the nasal passage are getting bigger and bigger and bigger for every breath. Tripod positioning in children where they're sitting straight up with their hands down between their legs, they're leaning forward. Sniffing position is back here. They're trying to keep their airway open. And of course, labored breathing. They're having a tough time. They can't breathe well. Noise. I like noises. I don't like noises, but if I hear noises, I know what to do. It gives me an idea of what's going on with my patient. Respiratory distress. We have distress, we have failure, okay? Distress is hallmarked by increased difficulty breathing, okay, and an abnormal effort and rate. And sometimes we hear stuff, okay? Either way, it's abnormal, okay? It's abnormal. It's not right. It ain't right. All right, so there's your diagram 10-1. Notice I talked about failure and distress. The biggest difference between failure and distress is failure, now they're decompensated and they usually have a decreased level of consciousness, altered mentation, okay, altered mental status. All of this is very, very important. Study this chart. This is nutshell stuff, man. That'll lead you right down the pathway of figuring out what's wrong with your patient. So study this chart, 10-1. It's in your book. Failure, just talked about it. If they're at failure, poopy. This is not good. This is bad, especially in children. Once they get to failure, it's hard to correct. We got to figure out the problem is. Usually we have to get, advanced equipment out and those kind of things, which we don't want to do. We like to catch them and treat them in distress. Normally we like them normal, but once they get to failure, we have to get a little bit more aggressive. Okay, circulation. So now we've done A and we've done B. Now we're going to talk about C. The circulation is evaluated by how well are we circulating blood and oxygen. Okay, plain and simple. They go hand in hand. Is the patient pale? Do they look like a ghost? Are they red in color? Are they sweating profusely and we're inside an air-conditioned room? That kind of stuff. What's their mentation? What's their mental status? Are they awake and alert? Person, place, and time and event? Okay. How's their pulse? Remember, I told you earlier about your first presentation and your first meeting your patient, feel their radial pulse. If they have a radial pulse, hey, they got a blood pressure of at least 90. So they're maybe getting close to shock, but they're not in shock yet. Once you lose that radial pulse, you're definitively getting into shock as an adult. Okay? Skin condition. Is it dry? Is it clammy? Is it cool? Is it just moist? You know, what is it? Assess these things. We have to touch our patients. One of the things that we're going to start doing with you folks early, as soon as we get through this assessment lecture, you're going to start touching each other and doing assessments. You've already going to be doing blood pressures on each other by this point, but now you're definitely going to be touching each other, talking to each other, doing assessments, you know, asking questions to start figuring out what's wrong with each other in a different scenario. All right, so determine the pulse is present. Okay, palpate the pulse. You can feel a radial pulse, you know, brachial pulse, a femoral pulse. These are all your carotid pulses. These are all your major pulses. If you cannot palpate a pulse in an unresponsive patient, do CPR. You remember this from chapter 14. All right, you've had that already. We've already done that. Right, so remember, CPR for those without a pulse. There's your radial pulse. Okay. Feeling for a radial pulse. Blood pressure needs to be at least 90 systolically. There's your carotid pulse. Ah, cute. There's your brachial pulse. We definitely feel that in infants. And you remember this from your BLS training, your CPR training. And finally, there's your femoral pulse. Okay. Skin condition, color, temperature, moisture, capillary refill. These are all important things. Capillary refill is important. We'll talk about that in just a second. So with skin color, poor circulation is going to cause the patient to look abnormal. Yeah, they're going to be blue. They could be pale. They could be kind of the ashen color or a gray color. When blood's not saturated with oxygen, it appears blue. Cyanosis. The word cyan, C-Y-A-N, means blue. Know that. Vital vocabulary. Cyanosis, blue colored skin, cyanosis. All right, high blood pressure, heat stroke, burns may cause abnormally flushed red skin. Liver disease and dysfunction may cause a yellowing called jaundice. Okay, and sclera as well in the eyes. You may see yellow there. You may see yellow in the skin. It can be so bad you can take a cloth and wipe it like a 4x4 bandage, and you end up with yellow on the cloth. That's the toxins coming out of the body. That's just awful. That's terrible. I've seen it many times with patients, especially late stage alcoholism with liver failure. Here's a little one. That's blue. This patient is blue. This is cyanosis. Okay. A little bit of oxygen. Hey, oxygen will cure that. This baby is, freshly born, not very old at all. A little supplemental oxygen will clear this right up. Temperature. Normal skin should be warm to the touch. Abnormal is hot, cool, cold, and clammy. So we want to make note of that. It all means something. Moisture. Dry skin is normal. We don't walk around all wet. Skin that is wet, moist, or excessively dry and hot suggests a problem. So we need to figure out the problem based on this. And remember, I was talking about how I put a hand on the shoulder. I can feel the temperature. I can feel the moistness. Okay, very important stuff. You get a lot of clues just by being nice, being introductory to your patient, and being one of, like I keep saying, the advocate for your patient. You've got to figure out, be that detective, but be that advocate as well. Make sure that you're doing what you can and what needs to be done for your patient. Do no harm. Capillary refill. Hey, that's a cool thing. It assesses this ability of the circulation system to restore blood to the capillary system. You squeeze a nail bed. Everybody do this. Okay, I want you to do it with me. Okay, take your finger, your 2 fingers here, grasp your index finger and squeeze on it. Index finger. Squeeze on the fingernail bed. Okay, squeeze hard. Watch it, watch it, watch it, and then let go. And see how quickly it goes from white to pink. It should be around 2 seconds. Okay. All right, so white to pink should be about 2 seconds. That should be normal. Fingers, toes. That's what we call distal circulation because it's down here. It's distal. It's away from your heart. Your central circulation is here. It's your core. Your peripheral circulation is out here. Okay, and very specifically, distal circulation all the way down at the end is your fingertips and down at your toes. That's as far as the blood goes. And then it does its thing down there in the capillary beds and returns back to the heart to get more oxygen. So, yeah, we'll talk about circulation system in detail as we get moving on. It's not difficult. You guys will do well. Just remember, study, read your book, make a plan, follow it, stick to your plan. All right, so assessment of circulation identifies and immediately controls any major bleeding. That's number one. Bleeding from an artery is characterized by spurting of blood flow. It goes, pss, 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 it squirts out. Venual bleeding, or from veins, it just kind of runs. And capillary bed, it just kind of oozes. So, whatever the level of bleeding is, we stop it. First way we stop it is direct pressure. Okay. Direct pressure, if that doesn't work, it's not quickly successful, and there's obvious arterial hemorrhage, then apply a tourniquet. We can do stuff about that stuff later. Stop the bleed. There's a whole program on that. Stop the bleed. We got to stop the bleed. Okay? Stop the bleed. Pediatric patients, considerations during the primary assessment. Okay? We use what's called the PAT triangle. There's a whole section on pediatrics that we will talk about it, but the assessment is very important. Use the PAT to determine if the patient is sick or not sick. When you walk into the room, I always tell people, in your general impression, sick or not sick. We really get specific on the pediatric patients because there's a triangle that helps us determine that right away. This PAT can be performed in less than 30 seconds. There it is. Okay, it's 3 things: appearance, work of breathing, and circulation. Somehow they missed down on the bottom, circulation on the red. I guess it's missing somehow. I just noticed that. Anyhow, appearance, work of breathing, and the red part is circulation. You start off with appearance. Hey, are they tracking you walking into the room? Then work of breathing, how is it? Is it good, bad, ugly? Are they not breathing on? And circulation, what color are they? So let's break it down. Appearance, note level of consciousness. Do they see you coming in the room? Are they playing with a toy? Okay. What's their interactiveness? You're going to determine their level of consciousness. If they're sitting there, you might want to go take care of them right away, but if they're sitting there playing with their favorite toy, yeah, I got my toy, and I'm looking at it, and I'm watching you at the same time, they're alert. Okay, so that tells you right now this is probably not an emergency, but we need to figure out what's going on. Then we're going to evaluate the child based on their level of understanding, level of development. We've already discussed that in the lifespan development chapter. And we're going to use the NAPU scale that's modified. The mnemonic, what we call tickles, also helps a lot. Tickles is in your book. It's a great mnemonic for children. It allows us to rapidly determine, whether the patient, meets certain criteria. First is tone. Okay, what is the tone of the patient's condition? Are they reactive? Are they talkative? Are they quiet? Are they silent? Those kind of things. Interactive. Are they playing with a toy? Next thing, consolability. Hey, is the patient, crying, and are they easily consoled? Are they looking and tracking at you for look or gaze in the L? And then finally, S, speech or cry. Are they talking, or are they simply only just crying? Those kind of things, because all of this means a lot when we're assessing children. There's the circulation of the skin, very much so the same. Same kind of assessment, if there's signs of edema, if there's signs of poor circulation, there's delayed capillary refill, those kind of things. These are signs that they have poor circulation, and we need to make sure that we present that to the paramedics that are coming so that they'll be aware of it. We can start working with it right away. Modeling is caused by a constriction of the blood vessels. Here's a particular scene where you can see the modeling there. Okay, that's generalized modeling. Okay, that means that there's not good peripheral vessel. There's constriction. So this means that this patient is trying to preserve whatever blood pressure they can because their peripheral vessels are constricted. So there's not real good blood flow. So they're in shock at this point. If you see this, this is a life-threatening sign that we can see the patient, what's happening to this patient. Hands-on primary assessment. Assess for treat life threats like you normally would, ABC or XABC. ABC for your nature of illness, XABC for your trauma patients. Airway. Hey, if it's open and patent, the patient keeps it open, great. Assess the adequacy. How's the air going in and out? If they're unresponsive, clear it and breathe for them. Make sure that we suction any mucus, vomitus, blood, foreign bodies in the airway before we start breathing for them. There you go, breathing, infant's child, expose the chest, look for chest rise up and down. Accessory muscles, that's when they're using their neck muscles or their intercostal muscles around their ribs. You can see that movement. You can see them really tugging on them hard to breathe. So these are things that are valuable clues for us to determine the patient's having problems. Circulation, we're at C now, determine if the patient has a pulse, is bleeding, or is in shock. Skin temperature, moisture, capillary refill, all good stuff. When you're doing your assessment, we always use PMS, pulses, motor, and sensory, and then CR, capillary refill, at the distal end. So we'll teach you this as you're doing your assessment, your head to toe, once we get into secondary. But it's very, very important when you do that head to toe to evaluate those components. APU scale, same as any other patient, alert, verbal, painful, or unresponsive. Exposure, okay, we need to expose. PAT requires that the caregiver remove the patient's clothing to allow observation of chest wall, the skin, that kind of stuff. Further exposure may be necessary. We want to avoid heat loss. For little kids, you're talking about, from a year to 2, you want to start working from the feet and then work your way up. It's less scary that way. For your older kids, you can work from the head and work your way down when you're doing your assessment. But overall, your primary assessment, we're only focusing on ABCs and then XABC for trauma. And then if they're unconscious and unresponsive, we go right back to chapter 14 and we start with CAB after we establish they're unresponsive. All right, geriatric patients. They have their own subset of conditions, and we're going to talk about that. Aging and disease can compromise the geriatric patient's ability to protect their airway. Their gag reflex isn't as normal as the younger adults or middle-aged. Their normal swallowing mechanisms could be impaired, especially as some kind of senile dementia or some oral dysphagia, into the mouth, those kind of things. Changes in level of consciousness, dementia, weakness, or paralysis following strokes can also affect the airway as well. So we need to make sure that the airway is patent, it's open, it's good, there's no obstruction in there, which could lead to aspiration, which means it goes down in the lungs. So we don't want that to happen. Circulation, poor perfusion for the geriatric patient is bad. Their lungs and their heart and their tissues generally, and their organs, they need all the oxygen and all the perfusion they can get. And physiological changes can affect it, affect circulation. Vascular changes make it difficult for us to feel radial pulses sometimes. And circulation problems, anything that you see that's circulation-wise, if they have a weak radial pulse, if they seem pale or they seem flushed, you need to help their circulation, give them an oxygen, because that's what we do as EMTs. We give them as much oxygen as soon as possible, and determine if they have some cardiac issues, if they have past medical history of heart problems, and of course, if they take any medications that may affect their circulation, such as blood pressure medicine. Transport decision, do it early. The patients that are elderly and the young patients, they don't compensate for very well for very long. Their reserves, especially in the older people, they run out. Okay, so it's very important for us to manage that right away. Any complaints that compromise ABCs should be transported as a priority. Older people will easily decompensate, like I talked about, and they may have chronic diseases that may create problems, with their health condition. Early ALS treatment and immediate transport is appropriate. Try to take the patient to a facility where they've been treated before, so the facility knows them, they know their medications, past medical history, their doctor, and all that kind of good stuff. And make sure that you take what they need. Be that advocate for the patient. Take what they need at the hospital. If you have time, make time. To make sure that they have, their toothbrush, their hairbrush, and an overnight kit, basically, whatever they need, their glasses, their dentures, their medications, those kind of things. And the reason why we take the medications, based on your protocol, make sure that your standing operation procedures allow that, is that way we can see how well they're taking their medicine. If a prescription was just filled yesterday, it should have one missing on it if they're supposed to take one a day, so on and so forth. So we can tell how well they're taking their medicines if we can count what's in the bottles at the hospital. Determining priority of patient care and transport. Hey, high priority, medium priority, low priority, there's all kinds of different priorities. These are your high priority patients, obviously unresponsive, they're having a hard time breathing, they got a lot of bleeding, altered level of consciousness, chest pain, they're pale, they're blue, those kind of things. If we have a young lady having complications during childbirth or any kind of severe pain, these are things that we need to prioritize and get them to the help that they need right away. So the golden hour or the golden period is the time from the injury to definitive care. Treatment of shock and traumatic injuries must be recognized and treated as early as possible. As it shows here, your first 20 minutes is discovery of the incident and activation of VMS. And then we have what's called the platinum 10 minutes. That's when you get on scene and you actually start to assess the patient and provide intervention. You get them to the transport, you get them to the hospital. Now we've burned up a whole hour. So as quick as possible. Those platinum 10 minutes are very, very important. As soon as we make contact with our patients, we need to get them transported as soon as possible. I always tell even my medics, your patient belongs in the hospital. There's very limited what you can do in the field. So we need to get them as soon as possible. Transport should be a priority for our sick patients. Transport decisions are based on these categories, patient's condition, the availability of advanced care, and you may have to meet up with an ALS unit. If you're a BLS unit, you may have to meet up with an ALS unit because they're closer than the hospital. It's called ALS intercept, and we're going to talk about that. Availability, distance of the transport, how far is it, to the hospital, and then of course following your local protocols. History taking. All right, so listen, we've moved now. All right, so we've done scene size up, scene survey. We've done primary assessment. We covered pediatrics. We covered geriatrics. Okay, so now we're down into the history taking. We're at the third part of the assessment, the points of the assessment. History taking, super, super important. We need to know everything about the patient, okay? Especially we need to be documenting, when the incident happened, their age, their sex, their gender, identity, ethnicity, their past medical history, and their current health status. it's what will lead to in order to put that detective hat and apply their conditions to be able to determine what's wrong with them, what's their best course of treatment. Let's look at this. So looking at this situation, you've got a gentleman that's leaning over, okay? What looks like on the ground here, okay? There may be some vomitus that's here. I'm not sure. But, obviously, this is when you're first pulling up, taking a look, your general observation. Looks like police department has just arrived on scene. He's got his gloves on. That's awesome. I can't tell whether he's got safety glasses on or not. Looks like he has his bag over here. Looks like a first response kind of bag. But this gentleman is leaning forward. Okay. He's positioning himself to where he feels the best at the moment. He may be vomiting, don't know, but notice that these gloves are being worn. He's making contact with the patient. It looks like his left hand may be actually touching the patient. So this is all part of that general impression, seeing signs up, we're trying to determine what's going on, and we're doing our primary survey. And we're going to start, once we get through the life threats are okay, we're going to do our past medical history. So investigating the chief complaint. Investigating the chief complaint is gathering information. We need to know information from the patient. We need to identify any associated complaints, anything that goes along with it. I have chest pain and I'm short of breath. So chest pain is the primary complaint, our chief concern, and then the shortness of breath is the associated complaint. If the patient is unresponsive, gather information from people on scene, bystanders, clues, what's laying around the patient, what's the environment, is it smoky, is there chemical in the air? I mean, what's going on? Is there anything that is in the environment that may be affecting this patient? And identify the patient's pertinent negatives. That's pertinent negatives. The pertinent negatives, they're negative findings that warrant no care or intervention. Pertinent negative, you got a patient who's unconscious and he looks like he's got a small laceration on his left leg that's healed. Okay, so that's a pertinent negative. It has nothing to do with his condition. If it's already healed up, I'm sure it doesn't. But we're examining the entire body. But if you find negative findings that warrant no care or intervention, then that's a pertinent negative. So we need to make sure we take note of those. This is our tool, okay, our mnemonic that we use, sample history, in this assessment on history taking, signs and symptoms. Sign is what? Right, it's anything you see, okay? Symptoms is what? Correct. It's what you're being told, okay? Anything that you're being told. Allergies, you want to ask, you have any allergies to medications? You have any allergies to food? Because if they ate a cookie and they're allergic to nuts, there you go. And they're having a hard time breathing, upper airway obstruction, it could be the problem. Medications, what medications are you on? What's the strength? What's the dosage? And have you taken it recently? What was the last time you took it? Pertinent past medical history. What do you take these medicines for? Okay. High blood pressure, high cholesterol, asthma, COPD. What are you taking the medications for? And the last known meal, okay, last known meal was the last time you had something to eat, okay. That's going to give us an idea, especially if they're diabetics, okay. And then the events leading prior up to the injury or illness. What happened? Remember when we talked about person, place, time, and events? We've already answered this, but now we're going to reconfirm it. Maybe you get some additional information. So sample. Sample is what we use for our history taking. Another good tool for any time that they have pain or if they're having respiratory difficulty. Onset. When did it start? Provocation or palliation. Provocation or palliation. Does anything make it better or worse? Okay. Quality. Tell me about it. Describe it to me. let them describe the pain or let them describe the difficulty of breathing that they're having. If they're talking in short sentences, I can't really tell you much. That's a problem. They're having a hard time breathing and they can't make complete sentences without breaking them, then they're really short of breath. The region or radiation. Show me where it hurts and does it, point to it and does it go anywhere? Do you feel in your shoulder? Do you feel it in your neck? Or does it travel anywhere? And the severity. We use a pain scale of 1 to 10. 1 being no pain, 10 being worst pain you've ever felt. We always like to qualify a number because as we treat, it may get better. And so we can report that, especially if you're helping them with their nitroglycerin. If they have chest pain, they prescribe nitroglycerin. We'll talk about that later. You're going to give them a dose you're going to assist them with a dose of nitroglycerin, and it may go from a 10 down to a 4. We made a difference there. Okay, so we want to be able to describe that. Timing. It's not the time on your watch. It's timing, meaning does it come and go or is it constant? Come and go or is it constant? So pediatric patients, when you're talking to them and you're talking about their chief complaint or chief concern, again, it all depends on their growth development. Remember, an infant, toddler, preschool age, you're going to get that from the parent or the caregiver, because they're not going to really be able to explain that they've had diarrhea and vomiting and they've, had a lot of diaper changes lately, those kind of things. So you're going to have to get that. But when caring for an adolescent, most of the information will be obtained from the patient. Do remember modesty. You might want to, talk to them away from the parents, especially when you're talking about sexual activity, both males and female. It's both, okay? And then, of course, with the females, possibility of pregnancy or any drug and alcohol use from either sex. You want to do that away from the caregivers, the teachers, the mom, the dads, that kind of stuff, because hey, you want to keep it as sensitive and as private as possible to preserve their privacy and also their modesty. Don't forget their modesty. Same-sex caregivers, very important when that can happen. A man needs to take care of a male, and a female needs to take care of a female. So, there you go. That needs to happen as much as possible, when possible. Again, there you go. Question of parents or child about immediate illness or injury should be based on the chief complaint. When you're interviewing a patient caregiver or an older child, the effects of the illness or injury on the behavior. Does the child seem to be more tired? Are they more anxious? Do they not care? How are their eating behaviors? Their patient's typical activity level, is this different? Are they normally running around the room? And now they're just laying there. Or are they rather solemn or complacent in their daily activities? Recent eating, drinking, how much have they been peeing? Have they been okay with that? Change in bowel or bladder habits, especially diarrhea or polyuria, which means too much pee. They've been peeing too much, those kind of things. Because that gives us an idea of what their circulation status is. Their perfusion status, they may be going into shock because they've been sick and they've had vomiting and diarrhea or excessive urination. And then rashes. Rashes are the big one. Mom, does your child have any rashes on them? If you see any rashes, go ahead and make sure that you have gloves and go ahead and put a mask on because you never know, it could be meningitis. So rashes are, especially if they're associated with a fever, we need to take in consideration that this could be infectious. Any kind of rash, and especially if it's coupled with fever. Okay, pain scale is different. We have charts, okay? The charts, it's the Wong-Baker chart, Wong-Baker faces. It's very helpful. Have them point to how they feel. 0 to 10. 0 is no hurt, okay? This helps if they can point to it, especially if they're older, if they're, adolescent age, teenage, even child, school age child. Preschooler, maybe, but down below that is going to be cut off. Obviously, toddlers and infants is not going to be helpful, but your preschooler and your school age kid from there on up, it will be helpful. Geriatric patients, when investigating their complaints, um, again, it's very specific. Find and account for all medications, vitamins, everything. Obtain a thorough patient history, and is there any changes in their mentation or their level of consciousness? Get that baseline of mental status and find out, is it normal, from other caregivers or neighbors, that kind of stuff, best you can. Sample history, there you go. Chief complaint may be very relative to a medical condition. Meds, again, take the medications from the hospital. Another thing that you can do if there's some resistance there because people are afraid of their medications being lost, they're expensive, take photographs of it and go ahead and spill the pills out onto a table, a bright table, and take a photograph of the count and then put it back in. I'm sorry, a dark table, so that the pills will show up well. That way the hospital can see the drug and how many pills were in there, because we can determine by the date on the bottle if the patient's being compliant or not. It's best to take them with you, but sometimes they absolutely say, no, my medicine has been lost before and it's expensive, I can't afford it. I get it. Last meal, very important, especially if they're diabetics. What prompted the event to call? Find out that history, and then transport to a facility that they know. Don't take them across town. If they, take them to where they go. That's the best thing. If there's no emergency, take them to where they know. If it is an emergency, you have to take them to the closest hospital or do an ALS intercept and let them manage it. Identify perp negatives. Remember, we were just talking about it. We were just talking about, there are findings that really aren't related to whatever the problem is. So it's the signs and symptoms that the patient does not have, okay? Important negative findings are referred to as perp negatives. So again, we'll talk about this as we move along, especially when we're doing scenarios. They are applicable, read it in your book, but there are signs and symptoms that the patient does not have, but you know that they're going on based on your assessment. Critical thinking and clinical decision making in EMS, it's all based on this. Gathering facts, interpreting the data, determine what the problems, come up with a plan, communicate the plan to the team and implement it, and then reassess what you're doing. Is it working? Is it working for your patient? Very simple. Get the facts. Determine, based on interpretation of the data, what's relevant, what the problem is. Come up with a plan. Communicate the plan to the team. Everybody agrees on it. Implement it. And then see what happens. See how the patient responds to it. Do we have a good response, negative response, no response? And then, steer our treatment around that. Taking history on sensitive topics. We've talked about this, but this also applies for the elderly. Signs may be confusing, hidden, or disguised. Elderly, especially if they've lost their significant other, they become very reclusive, withdrawn. They may have alcohol problems. They may have drug problems. You never know. No matter what, gather the history. Know it may be unreliable. Don't judge the patient, and be professional on your approach. Absolutely 100%. Physical abuse. This happens. Very sensitive topic. You need to try to gather the facts, non-judgmental. Follow your local protocols on reporting issues. Don't accuse. Involve law enforcement as necessary. This person looks angry, and she looks, submissive and withdrawn and protective at the same time. She's holding him back. She's on the couch. Her legs are crossed. And he is just plain angry. Retreat. Make sure you're a safe distance, not within a striking distance. And involve law enforcement as necessary. And document. Document, be objective, and report the facts only. What you're told or what the patient tells you, what the individual tells you, the aggressor, and then what you saw. And that's it. No judgmentals. Not at all. Sexual history. Again, consider all female patients of childbearing age who report lower abdominal pain to be pregnant unless ruled out by history. Asked about the last menstrual period and if they use birth control or not. Ask about any vaginal symptoms, discharge, any odors, if you have a potential that you've miscarried, have you had a large menstrual cycle, those kind of things. For both sexes, inquire about urinary symptoms. Does it burn when you pee? Are you having a hard time going to the bathroom? Do you have any injury, any trauma, or any kind of skin lesions or anything like that involving your sexual organs, those kind of things? And now, if it's a real problem, they're going to be honest with you, they're going to be upfront because they're afraid. They don't want to screw up their childbearing years. So if there's a problem, they'll usually disclose that to you. And remember, do this in confidence and privacy with the kids, okay, as much as possible, to try to preserve that privacy. Sometimes it's not, you can't, and if you can't, you can't, and the parents, won't separate themselves, then you have to consider, is this the right time or should we let the hospital do it? That is a real, ethical kind of decision, ethical, moral kind of decision, but it's okay. It's not one of those ones that's life-threatening to let the hospital manage that, but you need to pass that information along so the hospital does ask the questions. All right, we're in secondary assessment now. May be performed on scene, but only if you're waiting on transport. You should never do a secondary assessment if it interferes with transport. Don't delay transport to do a secondary, okay? If we have somebody that we're waiting on transport, or if it's a non-emergency and I really want to do a secondary because I'm in the privacy of their own home, I'll make that decision. The purpose is to perform a head to toe. You have what's called, secondary exam that goes along with, starting from the head and moving all the way down to the feet, and then also assessing neurological conditions. And that's what we're kind of talking about here. We're talking about head to toe secondary assessment. And I do want to go back to the quick head to toe, the rapid trauma survey and the rapid scan, which the rapid scan is in the medical side, that's in the primary. And the rapid trauma survey, that's for your trauma patient, and that's in the primary. That's when we're doing blood sweeps and we're looking for tenderness, instability, and crepitus, and that's about it. But this is truly the detailed head to toe. You're looking in the eyes, you're looking in the ears, you're looking in the mouth, looking in the nose. You're really getting detailed on your exam. And it should be systematic. Jumping all over the place, you'll forget where you're at and you'll miss it. And besides that, it's very specific, but you need to get everything taken care of or everything assessed so that if there's a condition that warrants it, that we find, it may drive our course of treatment. Okay, how and what to assess? Inspect, that's looking at the patient for abnormalities. Palpation, touch, feel, you got to touch, you got to squeeze. You've got to manipulate, within boundaries, okay? And then auscultation, we're going to listen to the lung sounds that a body makes, using a stethoscope, especially the lungs. You can listen to lungs, you can listen to bowel sounds, you can listen to heart tones, you can listen to the neck for carotid pulsation on how the blood moves to the neck, all kinds of things that gives us clues on what's going on. DCAP BTLS, that's deformities, contusions, abrasions, penetrations, burns, tenderness, laceration, and swelling. Compare the findings from one side of the body to the other, okay? D, deformities. What does it look like? Does it look deformed? C, contusions. It's a bruise. A, abrasions. Everybody knows what abrasion is, road rash, P, penetrations. Anything poke through the skin? B, burns. Is there any burns? Any signs of burns? T, tenderness. Is there tenderness when I squeeze the extremity or I press down on the abdomen? L, laceration. Do you see any lacerations as you're doing the examination? And remember, look at those hands when you're doing blood sweeps and see if you see any blood on your gloves. And then finally, swelling. does the see any swelling of the extremity if there's a possible fracture there? Do you see swelling or distension of the abdomen? Those kind of things. Swelling on the head from a contusion. So DCAT BTLS. There's another one that we use as well. That's TIC. That's tenderness, instability, crepitus. Tenderness, if you feel tenderness, you squeeze it. Instability, if it doesn't feel like it's intact. And then crepitus is when two bone ends rub together. If you want to know what it sounds like, take a chicken or a turkey leg and hit it with a hammer and then go, that's crepitus. It's like, ugh. When you actually feel that with a person, it's not fun. It's not fun at all. All right, the goal is to identify the head injuries with the head to toe assessment. Let's talk about pediatric considerations for general systematic assessments. Physical exam, entire body when pediatric, help to identify, problems that were not obvious during the primary, which sometimes they could be, especially infants and toddler and preschoolers. Again, we always start at the feet in that age group and end up in the head. School children, adolescents, you can do the head to toe. So just some caveats here. All right, so here's the extent of the physical examination. It all depends on the situation. Head, nose, ears, mouth, neck, chest, back, abdomen, extremities, especially your pediatric and, your adults as well. Got to get a set of vital signs. The state of Florida, like most states, require EMTs to get 2 sets of vitals before that patient is transferred to continuum of care. That's on your first arrival, your first presentation, and after disposition. If you transfer it to another crew or if you take them to the hospital, you got to have that. Also, a focus assessment. A focus assessment means it's focused on one thing. Child has a broken arm. Everything else is good. He fell off the swing, broke his arm. He's 10, 11. He says, "Oh, I broke my arm," and all it is a broken arm. That's a focused assessment where you're going to focus on the arm. You'll splint it. You'll, make sure that we are checking for circulation and neurovascular status. But it's focused. It's not just for one area. Considerations for geriatrics under general systematic assessment. Older patient may not be comfortably exposed. I'm cold. Don't take my clothes off. I'm cold. And they may be modest as well, especially, age group. You got to remember, baby boomer age group area, they're in their 80s, 70s now. And, they don't want to be undressed. They don't feel like they should be. So consider the need to keep them warm as well during the exam. Blankets, keep them warm during your exam period. All patients, especially patients in shock, should be kept warm. Focused assessment. It's just like what we said. No significant mechanism of injury. They're responsive, medical patients, and it's just one thing. And it's typically is based on chief complaint. The goal is to pay attention to the part that's got the problem. Respiratory system. Okay. Expose the patient's chest. You got to look for signs of airway obstruction as well. When you're talking to the patient, inspect the chest for overall symmetry. Symmetry is going up and down okay, right? Listen to breath sounds, not through the shirt, under the shirt, expose, take a listen. Listen for those breath sounds. Anything that you hear that's odd is called adventitious. So whether it's wheezing or whatever it is, if it don't sound right, it's called adventitious breath sounds. That could be a test question. Measure the respiratory rate. Watch, got to do your watch. Count to 30 seconds and double it. Or count for 15 seconds and multiply it by 4. Okay? Very simple. Very simple. Look for increased work of breathing. Okay? Is it fast? Is it slow? What is it? Okay? Okay, there's an assessment of the pulse. Feeling the pulse. You can count respirations during the same time, but you got to be looking at your watch. During the primary survey, estimate the rate and note whether it's too fast or too slow. The exact count is important during the secondary survey. Okay. Here's the chart for normal respirations. This is table 10-4. It's in your book. Use that for your reference. Let me tell you something, folks. 12 to 20 for an adult, you're going to be asked that question. School age, preschool, toddler, infant, newborn, not as much, but that adult, 12 to 20, is definitely a test question. Your school age and preschool age, yeah, 18 to 25 or 20 to 28, yeah, maybe. But especially on the adults, 12 years and older, you're going to get asked this question quite a bit on your test, including National Registry. Respiratory rhythm. These are patterns, okay? Patterns of breathing. This is a normal description, shallow description, labored description, and noisy. Remember, quality, normal respirations are silent, they're regular, patient isn't anxious, they don't have issues, okay? But if you've got any of these conditions, you have a problem, and that you're going to need to address it. Oxygen, at least, okay? And understand when you need to ventilate patients. You have low flow, high flow, and assisted. Low flow would be like a nasal cannula. Higher flow would be a mask, and assisted would be a bag valve mask. Plain and simple, those three components. Breath sounds. You're issued a stethoscope. Use it. It is not a piece of jewelry you're wearing around your neck. It's for you to use. Place the diaphragm on the stethoscope firmly against the skin to hear breath sounds. Breath sounds to listen for: snoring, stridor, wheezing, crackles, rhonchi. We will be letting you hear these breath sounds with our mannequins. They produce breath sounds. They produce bowel sounds. They produce heart tone sounds. You're going to be listening to all these sounds so you can identify them. Note any abnormal breath sounds and then document them and pass it along to the person that you're turning the patient care over. All right, so here's locations of breath sounds. You both do an anterior and posterior, anterior to the front, posterior to the back. There's at least 6 places, 3 on each side in the back, okay? The upper, the middle, the lower. And on the front, you need to be at least the upper and the lower. And the lower is what we call it the apices. The top can be apices as well, but we want to get more of the mid area, the center part. Apice just means point or end. Okay, that's test question, vital vocabulary, folks. Remember that. You can see that. The apices are here. Okay, this is the apice of the lower left lung. This is the apice of the upper left lung. Remember, it's always the patient side. This is the right side, and this is the left side. Okay, need to remember that. Those are definitely testable material. Definitely, definitely. Pediatric patients in the respiratory condition and other considerations. You will see what's called the Broslow tape. This is what this is called. It's used as a length-based measurement tape that the paramedic may use or may ask you to use. We're going to show you how to use this and how to gauge it in case you're asked. It'll be a part of your pediatrics section. Respiratory rates can be difficult because they're rapid. In case of infants, they may be crying involved in this as well. And as children younger than 3 years, you need to evaluate the respirations by considering the rise and fall of the abdomen, because they kind of bounce, kind of like a seesaw. So you need to do the best you can to determine how many times that goes up and down. Geriatric patients, there are considerations. During respiratory assessment, allow the patient to maintain position of comfort. Usually that's sitting up. They like to sit up. Chest rise may be compromised by increased chest wall stiffness, especially if they're smokers. They end up with COPD and their chests are real elastic and they're kind of round shaped or barrel shaped. And then of course sometimes they have poor circulation, vasoconstriction, hypotension, hypothermia, lack of red blood cells, carbon monoxide poisoning, all kinds of things. I kind of go back here. Poor circulation, vasoconstriction means the vessels are squeezing. Test question. Don't forget that. Vital vocabulary. Hypotension. Hypo means less or too little. Hypotension, so that's low blood pressure. Hypothermia, low temperature. Okay, they're cold, they're hypothermic. So these are all considerations with the geriatric patients. All right, so let's talk about the cardiovascular system and assessment next. All right, cardiovascular system. Look for trauma to the chest. Listen for breath sounds. Consider the pulse and respiratory rate and the blood pressure. All this comes in together. Pay particularly attention to the rate and quality of that rhythm. Is it fast? Is it slow? Is it regular? Is it irregular? Consider your findings when assessing the skin as well. Is the color bad? Is it bluish looking? Is it very red looking? And then check and compare distal pulses, and then auscultate lung sounds as well. For any, when you're considering auscultation and lung sounds, you're also at the lungs. Listen to the heart tones as well and see if anything just jumps out at you. I mean, it's always good to listen to heart tones. And if you're with a paramedic, ask him to help you out and give you some more information on what the heart tones mean. This table is normal ranges for pulse rate. A good thing to remember, this all ties into the cardiovascular system. Adults, 60 to 100. Okay, 60 to 100. 100 beats per minute or greater is described as tachycardia. That is vital vocabulary. And below 60 is bradycardia. Vital vocabulary. Tachy means fast. Brady means slow. Okay. Tachypnea. Bradyapnea, tachypnea means too fast breathing. Bradyapnea, that means slow breathing. Well, now cardia is heart. So tachycardia is a fast heart rate, bradycardia is a slow heart rate. Remember, vital vocabulary. You will see this stuff. You will be tested on this in multiple forms. Pulse quality, bounding, weak, thready, can be described either way. Bounding is when it's really thumping. When you're feeling the pulse, I mean that pulse wave, boom, boom, boom. The pulse is what we call the cardiac wave. It's the force of contraction of your ventricles. So it can be bounding or it could be weak, it could be thready. Thready means it's very, very hard to feel. It's very loose. You squeeze on it just a little bit and it goes away, that kind of thing. Pulse rhythm, regular or irregular. Either it's beating regular or it's beating irregular. And when you're in paramedic school, this is a big thing because it tells you what's going on with the EKG of the heart. It gives you some IDs, gives you some clues. Blood pressure. Blood pressure is the circulating blood against the walls of the arteries. A drop in blood pressure may involve a whole bunch of stuff. Loss of blood or fluid, okay? Loss of vascular tone. Vascular tone just means how well does our arteries and veins squeeze, okay? There you go. See, you got a hole that big, and when you have vasoconstriction, it becomes that big. It squeezes down, okay? It gets tight. When you have vasodilation, okay, it gets big again. All right, so constriction, dilation. All right, so that's vascular tone. And then arterial constriction is important. That's how we keep our blood pressure up, our systolic pressure. And then the cardiac pumping problem. Maybe the pump's busted. It's not working so good. Okay, and that could be a problem with blood pressure. Untreated abnormally high blood pressure can lead to stroke, heart attack, heart failure, or damage to the heart itself or other major organs. If somebody says, I've been living with hypertension and not taking medicine, that's a problem. Your patient, if they're experiencing chest pain, could have some significant event if they haven't been managing their hypertension, or if they have paralysis or paresthesia, slurred speech, droopy face, all that kind of stuff. They could be having a stroke. So very important to recognize those symptoms. Blood pressure cuff with gauge contains the following components: a wide outer cuff, an inflatable wide bladder, a ball pump with a one-way valve, and a pressure gauge. You've been trained in this already. You need to do manual blood pressures, and you can't always always trust the machine that you're using. It may be incorrect. When in doubt, take a manual blood pressure. Different sizes. You have different sizes of blood pressure cuffs. You have the extra large, the medium, and the smalls. That extra large is used for obese. It's also referred to as a thigh cuff as well. You can actually take a blood pressure in the thigh using the popliteal artery behind the knee. So, you know, all kinds of different ways and all kinds of different sizes blood pressures to fit our patients. All right, auscultation is the most common means of measuring blood pressure. This is when you can hear the systolic and the diastolic. This is skill drill 10-2. You've been trained in this already. Make sure that you can do it. You're proficient at it. If you need help, hey, we'll help you with it. We have mannequins that create blood pressure, where you can auscultate it. We also have each other. We have dual-headed stethoscopes, all kinds of stuff to teach you. So if you're having any doubts or any confusion, let us know. Now, palpation method doesn't depend on you using a stethoscope. And all you can get by palpation is the systolic blood pressure. You need to be proficient on both types of blood pressures. Normal blood pressure. Hypotension is blood pressure that's lower than normal. Hypertension is blood pressure that's higher than normal, hence the names. The prefixes. Hypo means low, hyper means high. Okay? This table represents, it's 10-7, it's in your book, it represents the normal range for systolic blood pressure for the different age groups. Adults 18 years and older, between 90 and 120 is nice. Pediatric patients, the cardiovascular assessment, appropriate size equipment, make sure you have the right size blood pressure. The cuff should only cover 2/3 of the upper arm. That's a test question. Write that down. Circle it, man. Circle it. This one here, man. That's a test question. Formula 70 plus 2 times the age in years. That's definitely something that you can use as a tool for systolic blood pressure. It's a useful tool in use in children that are from 1 year to 10 years of age. And you may see that on a test, so be familiar with it. Geriatric patients, they're a little different, okay? Cardiovascular assessment, vital signs may be different. They may have weaker and irregular pulses. The blood pressure tends to be higher, and the capillary refill is really not a good assessment tool because their circulation down here in their fingers are not as good. So generally it's cold. So with coldness, you have constriction. If you have constriction, it's trying to keep warm, so you're not going to have a whole lot of vasodilation because it's pushing the blood away. It's sending it back to the core. So you can't really rely on capillary refill as much. Let's talk about neurological system. Neurological assessments are important. They should be performed with any patient who has a change in mental status or if they have a head injury, okay? That head injury may or may not cause any kind of altered mental status, but you never know unless you assess it. If you have a patient that has stupor, otherwise they have a decreased level of consciousness to the point where they can't really be aroused, or if they have dizziness or drowsiness or syncope, we need to do a neurological assessment. Evaluate their level of consciousness and their orientation. Are they awake and alert, person, place, time, and event? Use that APU scale. Then you can use the Glasgow Coma scale. You'll be trained in that in the trauma section. It's a GCS score, can be helpful in providing additional information on their mental status changes. There's all kinds of mentation tests that you can give. Primarily in EMS, we use GCS, and we'll talk about that when we get to actual trauma and the neurological emergency section. Pupils, what do they mean? Normally round and approximately equal or move equal size, move, react together, and adjust their size depending on the availability of light. About the size of a pencil eraser, okay, about 2 to 4 millimeters. 4 is about the standard. And the dynamic reactivity of light can reflect based on the brain's perfusion as well, on how well it works. When a light shines near the eye, both pupils should constrict equally to the appropriate size. So they should come down equally to around 2 millimeters, which is smaller than the tip of an eraser or the end of an eraser, but a little bit bigger than the tip of a pencil, okay? So they should come down to an equal size. They should constrict when light hits them. And what it's doing, it's reducing the amount of light coming into the eye so it doesn't blind you. You don't need that much light coming into your eye when you're out in the middle of sunlight, but your pupils dilate when you're in the dark so you can see better. All right, so here are pupils, as you see on the top left, okay? That could be normal, to constricted, depending on the patient. It's pretty small. The one here, this would be your normal one, okay? This is dilated, okay? As you can see, they're pretty big, comparison. That's pretty small, it could be the, for that patient size, that might be okay for the patient status, but in normal people, that's pretty small. I would call that constricted. It needs to be a little bit bigger than that. It needs to be the size of a pencil. So that's constricted. This is dilated here. And then finally, you have unequal pupils. Unequal pupils can also be naturally occurring in a patient if they have a condition called anosogora. That's a test question on National Registry. Naturally occurring unequal pupils can be caused by a genetic inherent disposition called anosogora. All right, so small number of the population, abnormal reactivity or unequal pupils, that's what we were just talking about, the anosogora test question. And abnormal pupil response can indicate altered brain function. So that's for sure something we need to look out for. All right, so PERLA is a useful assessment guide for the eyes. Pupils are equal, round, regular in size, and react to light. Pearl, okay, Pearl, P-E-R-R-L. Pupils are equal, round, regular in size, and react to light. Good stuff. It's a good way to describe it in your reports. Neurovascular status, that's a hands-on assessment to sensory motor response. Check for bilateral muscle strength or weakness. Have them hold your 2 fingers, okay? Hold both hands and have them squeeze and see if their grip is equal and strong. Sensory assessment, can you feel me touching you? Can you wiggle your fingers? Remember we talked about pulses motor sensory earlier? This is that assessment. So when we're down at the extremities, we feel for a pulse in the radius, the upper extremity. We will now test motor, say wiggle your fingers for us, okay? Can you feel me touching the bottom of your hand? Just take your finger and rub it on the bottom of the hand. And they'll say yes, or maybe they'll say no. And we need to see if they're equal on both sides. And you want to test it, distal and proximal. Distal being down towards the feet, proximal being towards the head. So do the hands and the feet. Anatomic regions. We learn this in human anatomy. Head, neck, cervical spine. Palpate the scalp, the skull. Check the patient's eyes. Check the color of their sclera, which is the inside tissues underneath the eyes. Press on the cheekbones. Check the patient's ears for nose for fluid. Check the upper maxillae. That's here. Maxilla. Here. Mandible. Jaw. Open the patient's mouth and look for any broken or missing teeth. Note any unusual odors in the mouth. Don't describe it as alcohol because you don't know what that is. Just say there's a sweet smell of the breath, kind of thing, because that's all you're going to know. You're no expert in describing what people's breath smells like. So be careful in your statements and your reports. Chest, visualize, inspect, and palpate. Watch for both sides of the chest going up and down. Observe for normal breathing signs. So now we're going to move to the abdomen. We start with the head. We've done the head, the scalp. We've done the eyes, we did the ears, nose, looked in the mouth. We've gone to the chest, and don't forget, we're also going to auscultate while we're here at the chest. Listen for lung sounds. Move to abdomen. We're going to palpate the abdomen. Okay, we're going to do 4 quadrants. There you go. The right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. We're going to palpate all of those areas, those regions. If the person is hurting here in, say, the right lower quadrant, don't start there first. Start way away from it. Start in the left, okay? Move to the right, okay, upper. Then move to the left lower. And leave this one alone. You already know it hurts. Don't press on it. It's okay. Believe them. You might cause damage, especially if it's the appendix there that's complaining, or it's, you have appendicitis. You don't want to go pushing down on it. So don't do that. Just don't leave that one alone. Believe your patient, but assess the other quadrants for pain. Pelvis, symmetry, and any obvious signs, so bleeding or deformity. We're going to squeeze gently in, okay? Push gently down, all right? See if there's any instability. If the patient complains of pain, or if it doesn't feel right, leave it alone and bind it, stabilize it. We're going to talk about that later in injuries, in pelvis fractures and that kind of stuff. We'll teach you how to bind a pelvis, how to stabilize it. But this is the assessment portion. And, we're moving down. Okay, we've left the abdomen now. Now we're at the pelvis. Now we're going to go down further, and we're going to go to the extremities. Inspect the extremities for any cuts, bruises, swelling, obvious injuries, bleeding. Palpate for deformities. I like going to the lower extremities first. I'm already down in the pelvis, go to the lower extremities, and then make sure when you get to the distal end, you're checking for pulses, motor, sensory. Remember that, that's important. Pulses, motor, sensory, and capillary refill. Pulses, motor, sensory functions, plain and simple, okay? There you go, pulses. You're feeling for a pulse, there. You're feeling for a pedal pulse on the top. That's posterior tibial pulse. You want to check for sensory. You want to check for capillary refill. All this stuff. Posterior. You're checking the back, okay? If you're putting the patient on a backboard, or plain and simply, you want to look at the back, we need to inspect the back. If you've got a patient that's sick and ill, we're going to look for any bruises, deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, decubitus if they're elderly, otherwise a breakdown in the skin, any open wounds, any symmetry. We're going to take a look, and this is how we do it. Sweep the back with a gloved hand. Now this person's a trauma patient. Notice that this person here, okay, in this area right here, okay, they're holding C-spine, okay, they're doing a log roll, all right, and this person here is sweeping the back and see if you can feel anything wrong with the spine. If there's any unevenness or step-offs, or what they refer to it as, of the spinal column, they should all be in line. One shouldn't be protruding further than the other. Okay, using appropriate monitor devices. Devices never should replace, your assessment, but there's some nice things. Here's the pulse oximeter. We talked about this before. This number here, okay, represents saturation. It's counting saturation of molecules on the blood cells. Okay, hopefully it's oxygen molecules, and it says it's 93%. So remember, our target's 94%. 94 to 99 is usually that range. This number here, okay, is the pulse rate. It is the pulse rate, okay? So this is pulse oximetry. I keep one of these in my pocket. When I'm touching the patient, when I slip down, before I put my fingers on my introduction, I've got person, place, time, and event. I'm touching the left shoulder or the right shoulder generally. I usually approach on the right if I can for whatever reason. I will slip this on their finger before I grab their pulse. All right, so I just slip it on there so it tells me what their saturation is on room air, and also if it matches the pulse that I'm feeling. So good stuff, really good stuff. So capnography, blood glucometry, and also non-invasive blood pressure. There you go. There's your Life Pack. That is the Life Pack 35 series or Life Pack 15 series. Yeah. Anyhow, regardless, that's the Life Pack 15. And what it does, it gives us a lot of information. This is what our paramedic uses. You're going to be taught on how to place the leads, both capnography, the EKG leads, 12 lead EKG, blood pressure cuff, all that kind of good stuff on the patient. Now, one of the things that you're going to actually do on each other is blood glucometry, is where you're using a glucose monitor. So, but this is an EKG monitor, specifically LifePak 15, and we're going to show you how to apply this, not how to necessarily use it, but at least to turn it on to get things up and running. Considerations during a focused exam for geriatrics, we use the diamond. Okay, G stands for geriatric patient. All right, be familiar with normal changes of the aging process with geriatric patients. We do get older, and there is some changes in our bodies as we get older. You need to be aware of those and how they apply to patient conditions. The E stands for the environment assessment. Look and see if there's anything that would cause an emergency, slip and falls, that kind of stuff. See if there's plenty of food in the refrigerator, if the temperature is good, if it's clean, those kind of things. These are things that we're going to pick up to see how well our patient is living in their environment, and it helps us a lot. It gives us clues that leads us to the patient's conditions. M stands for medical assessment. We got to do our medical assessment. We got to look at all the medications. They could be numerous, medical history. All this is very, very important. And the S stands for social. We need to find out what their social status is. Do they go play cards? Do they have neighbors? Do they have a loved one still? What is their social interaction? I also like to find out, what's their drinking, history. What's their surgical history. All of this, to find out where they're at on it. That's very important. If the patient's having issues, they can get assistance. They can call 211. That's a phone line for geriatrics, so that maybe they can get the help that they need as necessary. All right, so reassessment. We're at the last. This is number 5 of the assessment. Okay, reassessment. Perform, identify, and treat any changes in patient condition. This is when we go back to the primary and we take care of our ABCs again and make sure everything's working. We repeat that primary assessment. We repeat vital signs. We had a baseline vital signs. Now we're getting our second vital signs, and we're looking for any trends. Was it high then? Now it's low. Is there any changes? Compare those baseline vital signs. Reassess the chief complaint or chief concern. Has it gotten better? Did the oxygen help? Helping them with their nitroglycerin, did that help? Recheck any of your interventions and identify and treat any patient's conditions that are changing and document those changes. Patient is unstable condition, they should be reassessed every 5 minutes. Okay? If they are stable, every 15 minutes. Test question. Make sure you write down this. Make sure you write it down, make note of it. If they're unstable, okay, 5 minutes. If they're stable, 15 minutes. These are our reassessments on our patients. Okay, so you need to make sure you know that. You'll see those on a test for sure. All right, so pediatric patients, patient and caregivers are often very, very helpful. Those big time helpful. They can help to reassess the effectiveness because they know their child better than anybody else. So they can be super, super helpful in that reassessment and the assessment all the way through. So take advantage of that every opportunity you get. Special challenges. Okay, special challenges, silence. Patience is extremely important when caring for patients who say little to nothing. Take your time. Don't rush them. Don't challenge them. Okay. Use closed-ended questions that requires a simple answer, yes or no, and consider whether silence is a clue to the patient's chief complaint. Is there depression going on? Are they isolating? What's going on? So take some special considerations with that. Overly talkative. Reason why the patient may be over talkative is caffeine consumption. They've got too much of it, too much Red Bull kind of thing. Nervousness, stimulants such as cocaine or methamphetamines, or they may have an underlying psychological issue. Try to calm them. Treat their anxiety as much as possible, and try to keep them calm until you can transfer them over, if they need to another form of care, another level of care. Multiple systems. Prioritize the life threat stuff, the complaints. Start with the most serious and then end with the least serious. Plain and simple. Intoxication. Whew, never an easy patient to deal with. Do not put an intoxication patient or intoxicated patient in a position where they feel threatened. And make sure they always have an exit so they can get out. Because, and you too, you just definitely don't want to get in between them. They have a high potential for violence, so be careful. Confrontations do happen. You want to avoid this. Alcohol patients, their senses are dulled, their inhibitions are dulled, they're liable to do anything. So be careful and make sure you involve law enforcement early. Crying. A patient who's crying may be sad. They could be in pain, or they could be emotionally overwhelmed. They're just kind of dumb, numb to whatever's going on. Remain calm with these patients. Be patient, reassuring, and maintain a soft voice. Confusing. They're confused. They have confused behavior or history. Could be all kinds of things, causing this low blood sugar, low oxygen, any of this kind of stuff. And then in older patients, they may have disease processes, what we categorize as organic brain syndromes, such as dementia, delirium, Alzheimer's diseases. They could be caused by a variety of things. Try to find out what their normal mentation is. We talked about this earlier, and see if this has changed, if this is new for them. If it is, it could be something, an acute condition that warrants immediate transport with an ALS unit. So you would want to contact them. They could be having a stroke. You never know. Don't play with these things. Make sure you recognize them early and get them the care that they need. Limited cognitive abilities. There are people, their mentation just aren't as well as others. um, be patient. Take your time. Keep your tone and your questions very simple, very direct. Don't use medical terms. Threw that out the window a long time ago. It's much easier to talk plain English. Be alert for partial answers and keep asking questions. Rely on presence of family and caregivers because they can help you out a lot. Bystanders sometimes, those kind of things. Anybody that knows the patient can be very helpful. So don't exclude them from the assessment. Cultural challenges. We have lots of cultures. We are diverse. We are a big, diverse population. We've talked about this earlier in other chapters. Don't ask questions using healthcare terminology. You're going to blow them right out of the water. Learn about cultures or patient backgrounds, that you might encounter. If you have a certain culture that's in your response area, learn about that culture. Go look it up or go meet with somebody that you can talk to that is from that culture, and see what to expect and what to do and what not to do kind of thing. It's the not to do's are the big ones. Gain assistance from the patient's friends, family members if you're on scene, and healthcare clinicians and with the same cultural background. And if it's English versus their native language, get somebody that can interpret what's going on, that can tell you what's going on with the patient. Language barriers, we've talked about that. Okay, this happens. If you can, learn some of the local language that helps you identify certain things like chest pain, shortness of breath, abdominal pain period, and let them point in the area. Keep questions straightforward and brief. use hand gestures, and get somebody who can speak the language to help you out. All right, let's do the review. Okay, real quick, we're going to go over this. I know we've gone for quite a while, a little over 2 hours now, but let's go ahead and knock this out. Okay, during the scene size up, you should routinely determine all of the following except. And notice they've used this big word, except. So there is one in there that is absolutely wrong. The rest of them you're going to do. So what do you think? What do you think, the exception? So during the scene size up, you should routinely determine all of the following except. Except. If you said B, you're correct. The components of the scene size up, that the number of adults and children, it doesn't matter in that initial. The others are much more pertinent. And here's your rationale. Okay. You arrive at the scene of an injured person. As you exit the ambulance, you see a man lying in the front porch on his house. He appears to have been shot in the head and is lying in a pool of blood. You should. What do you think? Okay. On the porch, shot in the head, pool of blood. What should you do? Injured person. That doesn't tell you anybody else is there. It's just you. If you answered D, that is correct. Okay. You're on a threatened position. You have arrived on scene. You don't know where the shooter's at. This may be self-inflicted, but it may not be. And the shooter may be right behind the door inside that front porch, and he doesn't want you helping him. You start helping him, they may come out and shoot you. Unknowns. When you have unknowns, don't risk your life. Call law enforcement, retreat, get out of there, safe place. Get out first, call law enforcement to the safe place, and have them make sure they respond. In reality, law enforcement's probably already going to be there. This is one of those situations that they're going to be there and they're going to have you in a staging area. There's your rationale. Findings such as inadequate breathing or altered level of consciousness should be identified in the primary assessment. Life threats. That's a life threat issue. Rationale. Number 4, what do you think? Not. Look, this is a big word. It's capitalized. Folks, these are test-taking skills. This is why we do this, to help you spot this stuff. Which would you not detect while determining your initial general impression of a patient? Not. This is something you're looking for, or something that you can hear, that kind of thing. Not something you have to sit down and count. Okay. If you said D, you're correct. Okay. You have rapid heart rate, you have to sit down and count it. You got to detect it somehow. So we're talking about general impression. This is your walk up. This is what you first see. You haven't done anything. It's just what you're seeing. Rationale. Your primary assessment of an elderly woman who fell reveals altered level of consciousness and a large hematoma on her forehead. Uh-oh. After protecting her spine and determining and administering oxygen, you should. What's next? Okay. You've done your general impression. You've pretty much so gotten your primary because you got altered level of consciousness. So you recognize that there is a hematoma. You're protecting spine, you're giving oxygen. Rapid body scan, rapid trauma survey. Yes. B, you got to go from head to toe. We need to find other potentially life-threatening injuries. Rationale. A semi-conscious patient pushes your hand away when you pinch his earlobe. You should describe his level of consciousness as, come on guys, you know this for sure. C, yeah, responsive to painful stimuli. There we go. They're a semi-conscious patient. They're not alert, but they're unresponsive, or nor are they unresponsive. They respond to the stimuli. There's your rationale. Assessment of an unconscious patient breathing begins by unconscious. They're breathing. We need to assess it. Yes, we have to make sure the airway is open, so we position the airway. Okay, A, airway. Head tilt or chin lift or jaw thrust, one or the other. There's your rationale. Your 12-year-old patient can speak only in 2 or 3 words without pausing to take a breath. He has a serious breathing problem known as, we talked about this, remember? What is dyspnea? What's that word mean? If you said short of breath, you're there. 2 or 3 word sentences. It was right there in the question. You couldn't miss that one. If you missed this on a test, I'd be going, So yeah, there's your rationale. How should you determine the pulse in an unresponsive 8-year-old patient? 8 years old, 8. How do we do it? 8. They're not an infant, so how do we do this? Okay, they're unresponsive. All right, what's the first pulse that we feel in an unresponsive? You learned this in BLS. Yes, D. We're going to feel for the carotid. Okay, carotid, D. There's your rationale. Number 10, when assessing your patient's pain, he says it started in his chest but spread to his legs. What example of the OPQRST? Where does it fall in? Come on, you know this one. We talked about OPQRST. It's a great mnemonic. I use it all the time when I'm talking to my patients. It's really good. If you said C, you are correct. Good job. Good job. Here's your rationale. Very good. All right, folks, I know this has been a long lecture. 2 hours and 16 minutes is what I got here. Congratulations. Thank you for sitting through this. It is one of the most important lectures for your entire career. It's about assessment. Now, it's about putting it in action, doing all 5 points of the assessment. Scene safety, okay? Scene safety BSI, doing your primary, doing your history taking, doing your secondary, doing your reassessment. 5 points of the assessment, folks. I want you to be able to tell me that whenever I ask you. Going down the halls, walking around, I may ask you, what's the third part of the assessment? You better say history taking, okay? You got to know these things. It's been wonderful. I look forward to seeing you in class. I hope that you have a great rest of your day, and we'll see you next time.